a very warm welcome from the International CML Foundation. I'm Nicola, I'm the Chief Executive, and again, as we're settling in and seeing people join, just a quick reminder that the International CML Foundation, really our aim is to improve outcomes for people with CML all around the world. And so it's amazing to be here at these regional discussion groups focused on South Asia, because part of what we aim to do is really raise the bar of CML management through education. And this is exactly what these conversations are designed to do, as well as our other programs, our online activities where we share knowledge and expertise through the community. The other part of the work of the foundation is our global research networks, which many of you are involved in. We have the ICML Genomics Alliance looking at clonal hierarchy in CML. We have our Treatment-Free Remission Alliance looking at biomarkers for TFR. And then there are other projects that are currently underway. So CML and hepatitis B, a survey of practice, and pediatric CML treatment in lower middle income countries, which many of you from South Asia are involved in. And there's many more to come. So as always, please keep in touch with the foundation. We value your connections and collaboration and ongoing conversation. It really is through these conversations, these discussions, that we can enhance patient care. So thank you again for joining. I'm going to now hand over to my colleague, Arlene, who is the program manager for the ICMLF, and she's going to introduce today's session.
So hi, everyone, and welcome. What a pleasure it is to see you, and so many now familiar names and faces joining us in the audience. Okay, so our first topic for discussion today is TKI choice and sequencing of treatment in a world of increasing options. And it's a great pleasure to introduce our international expert for this topic, Professor Gianantonio Rossi from Italy. Gianantonio is preceded by his reputation, widely known and highly respected around the globe, and many of you in the audience will remember his great session on pregnancy and fertility, which he presented with Professor Ziba Aziz from Pakistan as part of this series of discussions last year. It's a real honor to share the platform with you once again. Welcome, Gianantonio.
Thank you very much, Arlene.
So nice to have you here again. And our regional expert for this topic is Dr. Tulika Seth, who is Professor of Hematology at the All India Institute of Medical Sciences in New Delhi in India. I had the great pleasure of meeting Tulika at the Indian Cancer Congress in Mumbai last November, and I'm delighted that she's joining us today. I hope that this is the first of many opportunities to learn from you, Tulika. Welcome.
Thank you. So the first case that we're going to be discussing is the challenges about choosing the first-line therapy. Now that we have so many different products available, it's sometimes difficult to select the right tyrosine kinase inhibitor for patients. So what are the things that we look at? We look at the so-called score. There are other scores as well that people use, the Hasford-Utah score. The ELTS score is the UTOS long-term survival score. But I think the goal that all of us have is to see what we can give to make sure that patients are able to attain the deep molecular response. And then we look at comorbidity, toxicity profile of the drugs that we have, the age of the patient and the goals that the patient may have for therapy, and other preferences and issues. Earlier, cost was a big issue, but now with many generics available, that is less important in our decision tree. So the first case we have is a 35-year-old female college professor. She's recently married. She presented with symptoms of fatigue and dragging sensation on the left side of the abdomen. And these are her hematological parameters. She had some mild anemia. She had a high white blood count. And her platelet count was normal. She had a big spleen, and this is not uncommon in India for patients to present with a very large spleen. Often patients ignore early symptoms and present quite late. She did have the RQ-PCR done. It was positive, and cytogenetics were normal. On her score, because of the very large spleen that she had, she was labeled as a high-risk patient, And since we have these four agents that we use in frontline therapy, the decision was whether to use imatinib, dasatinib, nilotinib, or bosutinib. And I think because of her young age and the high risk score, a lot of us would choose a second generation TKI. Now, when we're selecting out of the second generation TKIs, of course, we'll have a lot of discussion and we'll get the experts to look at it, but we also need to look at the patient and comorbidities. And there are several things that we have to look at here. So she's otherwise young, she's a little obese, she doesn't have any major issues except that she's pre-diabetic, but her lipid profile is actually quite deranged. And this is something that we see quite a lot in India. And because I was reading for this and I had some discussion with Dr. Rosti, they use different scores for patients in Europe for identifying the cardiovascular risk. And when I looked up those scores and some of the other scores, I found that there were not really very good scores to predict for cardiovascular risk in our Asian patients. And if you have the same cholesterol score in a European versus an Indian, the cardiovascular risk is much higher in Indians. So that was kind of interesting to note. So there's definitely some gaps in risk stratifying our patients. And we know that we have patients who have very bad risks for cardiovascular disease, diabetes, and triglyceridemia are some of the other additional risk factors. And many patients can have family history of these kind of disorders. So in European patients, the ESC score is very useful. There are other scales that are used in America. For Asians, we don't have any ideal score. The Q-RISK-3 score is used in England, and that seems to be one of the good scores for Asians because there were a lot of South Asians who were included in that. And in this score, along with the age, gender, they include ethnicity because they have taken into account the fact that even though most Asians are vegetarians and non-smokers, but they have other issues like the high blood pressure, cholesterol levels, diabetes, strong family history of heart disease, and other things may be there. So this was something that I thought was interesting and may not be factored in especially when we're looking at international trials or other trials. So if we do her Q-RISK score, even though she's a young woman and a non-smoker, her Q-RISK score is actually quite high. And apart from the lifestyle modifications that we will recommend, we have to factor this into her TKI selection because when we now have many tyrosine kinase inhibitors, and we can select agents that would have probably for a patient who is having these comorbidities. So maybe bosutinib could be preferred over something like nilotinib or dasatinib, but these are things that we can discuss. So with this, I open it up for discussion and comments for this young patient and how to handle the cardiovascular risk in Asian patients.
Gian Antonio.
Yes. Yes, but I mean, a short comment. Of course, the ideal drug looking at the comorbidities of the patient is imatinib, no doubt, because the risk of the cardiovascular problem is very high in this patient at being very young. So now we have safety from one side, and then probably looking or hoping for a deep molecular response, which is more reassured using a second-gen TKI. Of course, excluding nilotinib for the baseline characteristic. A choice between dasatinib and bosutinib. Clinical trials said that prospectively between dasatinib and imatinib and bosutinib and imatinib, dasatinib was a little bit more effective in inducing a DMR. And on the other hand, the cardiovascular risk at 5 years of bosutinib and dasatinib is not, so different, and is basically considered low. So my personal choice, even looking to the age of the patient, you noted that she had a very expanded disease, a very big spleen, but the LTS score was intermediate because she is young. And age is an important factor. But younger patients with CML are at higher risk, beside the risk score stratification. So my choice would be, honestly, Dasatinib 100 milligram daily for this patient. And then later we can, of course, discuss about my choice, what to become.
Yeah, so I think Bosutinib and Dasatinib both of these, I think, would be something that we could definitely think about. I think Nilotinib, I would definitely not be so happy about. I agree. I think Dasatinib is a very fantastic drug. And in case she responds well to Dasatinib, then maybe a couple of years down the line, TFR could also be a very good option for her. And so Bosutinib and Dasatinib, I think I would find it very difficult to choose. We could have a discussion with the patient in case she has any preferences, but both of them seem to be good. Any comments from Dr. Hemant or Dr. Massimo?
Yeah, I think that is an interesting case and not a very uncommon situation which we come across in our country. And I think in many other South Asian countries, a young age at diagnosis with some comorbidities, particularly prediabetes or diabetes and dyslipidemia. And I think Tulika mentioned that this patient was just married. So obviously she will not have any children and she would be very desirous of starting a family in the near future. So we would want a quick and deep response, and we would want a TKI which does not produce too many side effects with the comorbidities which the patient has. So that means that we would prefer to start with the second generation TKI again, because we want a quick and a deep response. And secondly, we would not use Nilotinib because we know that it worsens the hyperglycemia and it worsens the dyslipidemia. So I think the choice very correctly is between Dasatinib and Bosutinib. Fortunately, at least in India, and I'm sure in some other South Asian countries also, we have generics for both the drugs. So I think either one of the two would be a good choice to start. Thank you.
So if I can comment.
Briefly, sorry, just Massimo, just a few seconds. Don't overlook the fact that the risk of dying, of suffering of a severe cardiovascular event is in the next 10 years is probably much higher than the risk of dying of leukemia. So even the other parts of the story, so inducing this young female to do something to protect herself from so better lifestyle and this and that.
If I can comment,
sorry.
Professor Massimo, what do you think?
Yeah, thank you. I completely agree with Gian Antonio, Professor Hemant, and Tulika about the fact that Nilotinib is not a good choice here. Not only because she started with an increased lipid profile, but she has also a family history, if I read well. And I believe that Dasatinib is indeed a good choice, probably starting with 100 milligram and then lowering the dose after the achievement of a good and stable response to 50 milligram, because now we have the evidence that in the long term, even the low dose is similar to 100 milligram, and maintaining the good molecular response without the possible side effects and the off-target effects also of this drug. And if I read well, then I see that you wrote only one kidney. So probably Bosutinib is not a good choice here, again, because in the long term, as you know, has been reported with Bosutinib an increased renal failure after several years of treatment. So Dasatinib, I think that is the best treatment in a younger patients like that.
Okay.
if I may just, I'm looking at the chat, and Dr. Lalit Mohan Sharma has said, how do we start the Dasatinib 100 mg daily, or start with 50 milligrams and gradually build up to 100 milligrams? Myelosuppression remains a challenge for a few patients.
Tulika, who want to answer?
Well, there is some data on 50 milligrams. That is an option. Though what we try to do is we try to start with 100. If the patient has myelosuppression, we may then go down. But otherwise, if the patient is able to tolerate, and many of our patients are able to tolerate 100, that's what our preference is. We don't routinely start everybody on 50.
I'm personally not totally sure, because this lady has a very big spleen. So I mean that the risk of probably 100 milligrams straight from the very beginning probably would not be my preferred choice. And to do it the reverse, so starting 50 and then going up, because it's even my personal experience to have in relevant cytopenias with 100 dasatinib, but particularly on platelets when the spleen is very big at the beginning. So, but anyway, it's
No,
I
that,
don't know if other want to.
we do see cytopenias in some patients, but at the same time, we do have many patients, even elderly patients, who. But I think that's a very interesting point that you've made, and something that keep in mind. Thank you.
Yeah, yes. Yes, Tulika, you
I
see
would agree with
sorry,
Tulika. Sorry, go ahead, Tony.
No, I just to make the comment that but probably we are all experts of CML and drugs, but our personal experience then may influence our choice. And probably my personal experience is a little bit worse with respect to Tulika. But you know that is important, is to be minded of the problem and to face it properly, independently from the dose. Yeah.
So the majority.
Sorry, Amanda, please go on.
So as we generally see patients with very large spleens, and as I said, we don't always see cytopenias, but again, there are certain patients who always have cytopenias, and those are the ones then we have to reduce the drug. We see cytopenias even with imatinib and all the TKIs in some patients. Dr. Hemant, you wanted to comment?
Yeah, I think I agree with Tulika that it would be appropriate to start with the full dose. If you opt for dasatinib, then you start with 100 milligrams once a day. And fortunately, you can take it either with meals or without meals. So there are no restrictions with food when you're planning dasatinib. And you reduce only after there is a good molecular response or there is toxicity. Otherwise, my conviction is that one single arm study from one institution of 50 milligrams is not sufficient to at least convince me. So I would send a message from this platform that start with 100. If there is a toxicity, then reduce to 50. Thank you.
Totally agree, Amand. Totally agree about the 50 milligram dose.
Yeah, completely agree, even by my side.
So any other questions, or should we move to the next case?
I think we can move on to case number 2, and we will have a wider discussion at the end. Any questions which have come up with this one, feel free to just bring them back later. Okay, your second case, please.
Thank you. So in the second case, we have a 55-year-old gentleman. He has some irritable bowel disease, and he's a known hypertensive on medicines. And he's been diagnosed with CML-CP about 7 months ago in his hometown. There he had been diagnosed by a qualitative BCR-ABL, and he had been started on dasatinib, 100 milligrams, as the front line. He had been very motivated to attain TFR, and he's been very regular with his medicines. However, he's not very satisfied with the progress of his disease, and so he's self-referred to us. And the reports that he comes with is that his RQ-PCR at 3 months was about 15%, and his RQ-PCR at 6 months was 11%. So we are kind of seeing that we have a 55-year-old who was started on a second generation TKI as frontline. And even at 6 months, his RQ-PCR is more than 10%. So if we look at the ELN criteria, the milestones, his response at 6 months is not very good. So we are kind of a little bit concerned about him, especially since he's already been on Dasatinib. So we are kind of looking at a patient who may have developed resistance to a frontline second generation TKI. And I think one of the things that are important is, even though in India, we tend to use a lot of imatinib as frontline therapy, there are patients who are started on second line as a frontline therapy. And what needs to be highlighted is, if you are using a second line agent as a frontline, then if this fails, then you can't go back to imatinib. So, and you also, other second line may not be so good. And you now need to change this patient either to ponatinib or asciminib. So this is something that I think is important to highlight, because often we have patients who are on one second line and then they get rotated to other second lines, or even put on imatinib. So that's something that we are not really recommended to do. So obviously, when the patient comes to your center, you will want to do the tyrosine kinase domain mutation studies, and we outsource that. We also would repeat an RQ-PCR just to make sure that that was done as per the standardization, and we would do a bone marrow and send for karyotyping. And because we're thinking of ponatinib, we would do the cardiac risk score. And for ponatinib, there is a score 2 and score 2 OP that is recommended. And that's something that people would recommend to do before ponatinib. Now, if the patient doesn't have any other mutations, or even if he does, we would anyway be putting them on ponatinib or asciminib. But as I said, you have to look at the cardiovascular contraindications. So several questions here. One is, if we are using ponatinib, if the patient doesn't have any cardiovascular risk, would you do you start at 45 in all patients and then go down to 30, or do you start at 30? And what about asciminib? Because in many Asian countries, even in India, ponatinib is not easily accessible. It has to be imported, and many of my patients are not able to import it. We do have asciminib available either on compassionate use, and also now it is approved and available in India. So, so those are the two things that are there. And the other question that is also sort of a carryover from the first case that we had is that, again, the cardiovascular risk scores are again not standardized for Asian patients. So I think that's something that as a group in Asia, we need to think about looking at cardiovascular risk identification in patients, because the cardiologist really should do that. But since that hasn't been done, I think there should be a move from India to look at this, because that will help us in the ponatinib decision making. So questions from the larger audience and from Dr. Rosti, what would you recommend in a patient?
Gian Antonio, you start, please.
Yeah, thank you, Tulika. If we believe that the more than 10% qPCR is a resistance, as we do, of course, it's a frontline resistance, so it's a tough form of resistance. So looking at that, my brain is going to ponatinib, and in that case, probably 30 milligrams, because it's no mutation, is stable disease. I mean, over 10%, but complete hematological response. So not an expanded disease. So 30 would be enough. Looking at safety, my brain is going or to asciminib. We have no randomized trial to compare ponatinib and asciminib, but it's generally considered that when resistance is the bulk of the problem, as in this patient, probably ponatinib 30 milligram is a better choice, but even asciminib. So if I have to decide on site now, probably my choice would be currently asciminib, and then in case of further resistance to go to ponatinib 30 milligram third line at this point. We have no data supporting the notion that the patient failing asciminib then will be sensitive to ponatinib. But at least we use first an active and less toxic drug, and then as further rescue, we think to ponatinib. I don't know, this is my opinion, but you may have, of course, a different one. Happy to hear about from Hemant and Massimo about this. I don't know, Arlene, if now or at the end of the session, you are watching at the time passing.
It's okay. No, we're good for time, and I'm watching the comments coming up in the chat. Massimo, would you like to respond? And then Hemant,
Yes.
you have your hand up already.
Yeah. So my personal comment here is that it's a second-line TKI failure without mutation. So in my opinion, I would like to prefer to start with ponatinib, increase the dose for 45 milligram, because we have the important data of the OPTIC trial that show the efficacy in this setting of patients, very resistant, but without mutation, and then rapidly decrease to 15 milligram when the less than 1% of BCR-ABL was achieved. So asciminib in second line, I don't think this is possible now. We have in third line. Is a possible option. No, it's a possible option then if the patients have no answer in second line with ponatinib, even at a low dose. So even if we know that from the sponsored trial and even in compassionate use, asciminib after ponatinib is not rescue all the patients, but on the contrary, it's better to perform before asciminib and then ponatinib, because I don't think why. So the reason are not known, probably in the mechanism of action and in the allosteric inhibition, but is in second line is not possible. So we have no availability of this drug now.
Massimo, but if it would be possible, then imagine now we are third line. So after 2 months on imatinib, dasatinib, and then now we are in this situation.
Yeah. So again, I think that my personal opinion is ponatinib second line, because we have the data, Gian Antonio. So we have no data about the asciminib, and in particular the action of asciminib in this setting of patients. So without mutation, and resistant to a second generation TKI. So I think that is the worst condition that we can have in a younger patients with a resistant but not mutated. So probably here genomic studies show that these patients had somatic mutation that is now showed in several trials, such as ASXL1, and in which we know also that asciminib is not acting from the ASSEMBLE trial.
Massimo, you convince me.
Yeah.
You convince me. No, it's my discussion. No. I'm not joking, but because probably it's the best track is 30 milligram, and then decrease to 15 as soon as
even because
you're right.
Tulika showed that these patients had no cardiovascular contraindications. So I think is a possibility, to rescue these patients. We have very important data about the use of ponatinib in this setting of patients. We have no data about the use of other TKI in this setting. So very resistant patients without mutation.
Yeah.
Hemant, what do you think?
I have like a few comments to make for this patient of Tulika's. Number one, I would repeat his BCR-able one more time in a month's time and make sure that the BCR-able is more than 10%. Secondly, I would reconfirm his compliance, and from source other than the patient himself, I would ask his wife or I would ask his children that is he really taking the medicine? So the first thing which most of us should do when we see a suboptimal response to either a first generation TKI or a second generation TKI to make sure that the patient is compliant. So I think that is an extremely important factor in a country like India, and I'm sure in other countries also. So before you plan for any, aggressive change of treatment or for an expensive investigation, like asking for a kinase domain mutation by NGS, make sure that the patient is compliant. And in case the patient is compliant, his wife says that he's taking the medicines every day, and after 1 month his BCR-able is still more than 10%, then I would ask for a kinase domain mutation. And in addition to the options discussed by Dr. Massimo and Tony, I would also consider another second generation TKI because of two reasons, which is very important in India and other similar countries. Ponatinib is not available to us, very, very difficult to import, and asciminib is horrendously expensive. And there is a 10 to 15% chance that this patient might respond to bosutinib or nilotinib. So I would be happy to try that for 3 months, 6 months, and then consider maybe the extremely expensive asciminib or try to import ponatinib for this patient. So that would be my approach, like sort of a India-centric approach to this situation. Thank you.
Tulika.
So this actually is a very difficult situation. And when we faced it, it becomes quite problematic because we're not supposed to go to another second line. But as Dr. Hemant said, sometimes we do try that. But what I have found is when you have a dasatinib failure, then bosutinib usually doesn't work. Nilotinib plus minus may work. My question to Dr. Massimo was we have heard a lot about the ASXL1 mutation and when asciminib may not work. So before using asciminib or in failure of a second line, do we routinely do that? Because I wasn't sure if that was something that had come into practice.
No, it's not entered into clinical practice. We have only very few data and experimental data about the Australian, the German group inside the sponsored trial, and now we have the information in the assembled trial that was collected. But as you know, less than 10% the patients mutated, and we have no evidence that this type of information until now should enter into the clinical practice. Probably we have all these type of patients now very difficult to treat that are resistant even to second generation TKIs. Most of them presented, for example, hematological toxicity, so very soon during the first phase of the treatment. And I believe that in the next futures, for this type of patients, we have to refer it again for an allogeneic stem cell transplant and not for a pharmacological choice of treatment.
So that's what we do in India, because when we have failure to dasatinib or other things, because ponatinib, if we are using, because it is expensive, we usually only use it as a bridge to transplant. And so in India, transplant is still definitely there for patients who have failed second line or third line therapy, because that's still an option for us. It's more cost effective. Any open questions?
I have a couple of
I think
questions.
there is one question from Dr. Lalitmohan Sharma on whether if the patient has suboptimal response, would you ask for a bone marrow and ask for a karyotyping? So maybe Tony, you can take that. Is doing a marrow essential and doing the cytogenetics again for a suboptimal responder?
You mean No, suboptimal response do not exist anymore. No one want to be suboptimal. But anyway, I understood, of course, the question. Yes, bone marrow aspirate is needed because you have to clarify if the patient is still in clear chronic phase or not. And TKI mutation from blood is okay. Of course, bone marrow for cytology and cytogenetics, and peripheral blood for a mutational analysis. That's my opinion.
Yeah, complete.
I don't know.
Agree with Gian Antonio.
There is another another question before.
Any further comments on that one first, or should we move on
yes.
to Professor Biswas?
Yep.
Okay, we'll move on. So Professor Biswas says,
yeah,
35-year-old he was taking imatinib 400 for last 4 years. Initial risk was not documented, not being monitored by molecular assessment. Recently, she became resistant to imatinib 600, and kinase domain mutation analysis revealed double resistant T315I and Y253H, sensitive to dasatinib and bosutinib, but moderately resistant to ponatinib. What would be her TKI selection now? Gian Antonio, do you want to start? Everyone can have a go.
Even besides the moderate sensitive in vitro of Y253H to ponatinib, the presence of a T315 in a young lady probably has only one option, and is ponatinib 45 milligram starting dose. And of course, apart from economic reason of difficulty to import the drug in India, because if not, we have a PILUP mutation and the perfect mutation together. That is in a young lady, and then there are no options. Of course, if only the problem was the PILUP mutation. You can try dasatinib 100 milligrams, because sometimes in the clinic we have a positive surprise with the mutation potentially resistant to that drug. But at the present, using a drug active only on the PILUP mutation will open completely the door to the expansion of the alternative clone. So, in my view, is ponatinib 45 a sort of obvious choice in this young lady, with if you want a potential bridge-to allogeneic eventually. You can say then that, is a bridge to allogeneic, and then if the patient will respond well, then you discharge allogeneic and continue on TKI.
Is there any scope of giving combination TKI, provided there is no comorbidity to this lady?
Is that you, Professor Biswas?
Yeah. Is there any scope of giving combination TKI, double TKI, as the patient is having no comorbidity, actually? She is young and no cardiac or pulmonary comorbidity, actually. Is there any scope of giving both ponatinib and bosutinib to this lady?
Both. You said to give both the drug? No.
Both. Is there any scope of giving both? No. Okay.
I believe no. But is a compound mutation or two different mutation? This is the question, I believe, that is most important.
This is a Sanger, because probably together. Is a Sanger testing or an NGS?
It was Sanger, not NGS.
You understand? Of course, if an NGS will reveal that we have a PILUP mutation and a 315 as a compound mutation, the choice of ponatinib is even probably much recommended, because the compound mutation, are really highly resistant. They are few, at least in Europe. It's difficult to retrieve one, so not so frequent, but once documented, I mean, it's really a problem to induce a good remission. So it's ponatinib 100% and 45 milligrams 100% is starting dose. Then data from PACE and from Optica are much clearer on this point.
So I think there is significant synergy between the STAMP inhibitor and the TKIs, asciminib and the second generation TKIs and also the first generation TKI. And studies are on whether they will add to the response rate and whether they will be helpful in resistant patients. But the combination of two TKIs, first generation, second generation, or two second generations, that is not recommended because of there is no synergy with the combination and it's too toxic.
Any other thoughts on this one?
So probably, if I may comment on this, if it's another compound mutation, ponatinib 45 milligram is the better choice. If it's a compound mutation, indeed, even ponatinib probably doesn't work. So these patients are candidate to stem cell transplant because we have no data about the other activity. So we know from literature now that only in some cases of treated with the new drug that is not available, that is called olverembatinib, probably we have some responses about the compound mutation, but not in the other TKIs.
So Massimo, your conclusion is if an NGS reveal a compound mutation, which is a difficult task even for ponatinib, starting ponatinib and looking for the donor because
absolutely.
Yeah.
I think it's not a compound, so between the two mutations is T315I the most worst. So I believe that 45 milligram of ponatinib is the better choice here.
Yeah, agree totally. Yeah.
Julika, do you have a thought and then perhaps a closing comment from Hemant?
No, I think I would agree. T315I mutation patients are really difficult, and I think targeting that would be able to hopefully help the patient. So that's my comment.
Yeah, I think I agree. It is the commonest mutation happening in about 25% of patients, and we have quite a bit of data from India now. We have one large study published from Dr. Raghu's center, and Dr. Raghu is, I think, attending this meeting. Well, the first and the second generation TKIs don't work. Ponatinib is not available in India. Asciminib has just become available, so that would be the drug of choice, and it has to be kept in mind that when you are dealing with a patient of T315I mutation, then you have to use a much larger dose of asciminib, 200 milligrams twice a day. Most of us end up with, if there is a hematological response also, most of us end up in continuing the first or the second generation TKIs and combining that with hydroxyurea for the non-affording patient. And for the affording patient and the young fit patient, we start thinking of a transplant. So for low middle income countries, dealing with patients with T315I mutations is a really big challenge and a big unmet need.
Right, thank you very much. Well, that's our time up for the TKI choice and sequencing topic, I'm afraid. Dr. Gautam, I can see you do have a comment there. Please hold it over till the end. Let's see if we can get that up later. So thank you very much, not only Professor Gianantonio and Dr. Tulika, but also Professor Massimo and Professor Hemant as well. That was a really good discussion from all of you, and thank you to our audience members for getting involved. Please come back with other comments and questions later. Okay, so moving on to our second topic for today, anticipating and managing acute TKI toxicity and adverse events. and it's my very great pleasure to introduce Professor Massimo Brescia, who has done a very good job of introducing himself already, and only by coincidence, who also comes from Italy. Massimo is a great physician, a great researcher, and hopefully most of you will already have seen his Managing Intolerances presentation on the ICMLF Knowledge Center. If not, I'll direct you to it later. Such a privilege to have you here today, Massimo. Welcome.
Thank you so much, Arlene.
And also delighted to welcome Professor Hemant Malhotra from Jaipur in India. Hemant is a giant in the world of CML. He wears so many hats. I do not know how he keeps up with himself, yet he's always so generous with his time and knowledge. He's also very witty and lots of fun to be around. Thank you so much, Hemant, for joining us today. Really nice to have you here again.
Thank you very much. My complete pleasure to be part of this activity.
Hemant, the floor is yours.
Okay, so ladies and gentlemen, again, welcome to this South Asian program in the regional discussion groups being organized by the International CML Foundation. And please be aware that we're going to talk about acute TKI toxicities. And if you've looked at our program carefully, there'll be another session on chronic TKI toxicity. So let's see if we can focus today on the acute toxicities. So I bring you greetings from my Medical College Hospital and my cancer center from Jaipur. And I'd like to start by paying tribute to my very dear friend, Professor John Goldman, who was like a very strong India lover, and he visited India many times, and all of us have very fond memories of him. So ladies and gentlemen, we have these magic bullets for the treatment of CML. We have the first generation tyrosine kinase inhibitor imatinib. We have 3 second generation agents, nilotinib, dasatinib, and bosutinib. We have a third generation agent, ponatinib, and we now have a new STAMP inhibitor, which also can be called as a 4th generation agent, asciminib. And fortunately for us practicing in India, the top 4, the first and all the 3 second generation TKIs, and as well as asciminib, they are available in India. The first 4 are available as generics, so we can, kind of organize them for our patient at minimal costs. So this is one slide which I wanted to show you before I launch into my case. Please look at the inhibitory spectrum of the currently available TKIs. And I don't know whether you can see the pointer on my screen, but this, if you look at the first picture, which shows the kinogram of nilotinib, the first left red dot is the kinase inhibition of the BCR-ABL. The rest with nilotinib, with imatinib, with dasatinib, ponatinib, bosutinib are all inhibition of other kinases. So all our TKIs are basically dirty drugs. They don't only inhibit the target being the ABL. They inhibit several other kinases, and that is the reason why which we have so many acute toxicities and so many chronic toxicities. So in addition to the on-target effect of our drugs, our on-target being the inhibition of the BCR-ABL, there are several off-target effects, inhibition of these, as the SRC kinase, the c-KIT, the PDGFR, and several others which contribute to the toxicity of these agents. And some of the toxicities which we are well aware of, you usually have cytopenias with dasatinib, imatinib, nilotinib. You have fluid retention with imatinib. You have hyperglycemias and hyperlipidemias with nilotinib. You have skin toxicities, rash, predominantly with imatinib and nilotinib. You have pleural effusions and pulmonary arterial hypertension, specifically with dasatinib, and you have peripheral arterial occlusive diseases with nilotinib and also with ponatinib. And this is again the relevant TKI toxicities, which I think I'll just read out for you. When you think of imatinib, please consider and anticipate rash, fluid retention, edema, weight gain, musculoskeletal pains, diarrhea, and skin depigmentation. With nilotinib, again, rash is common. A lot of patients have headache. There might be disruption of liver functions and impaired glycemic control and dyslipidemias. With dasatinib, this is the most potent agent to produce bone marrow suppression and cytopenias, also produces pleural effusions. Bosutinib, the classical toxicity is diarrhea and liver dysfunction, can also lead to renal dysfunction. And with ponatinib, you have skin toxicities and hypertension. So these are the acute common side effects of the first and the second generation TKIs, which every physician managing CML must be very familiar with so that you can anticipate and prevent these toxicities. So I think this we've already covered, and we can give this a skip. And this is the data from the imatinib study, the IRIS study. And you can see that almost 50% of the patients will have some fluid retention, nausea, muscle cramps, musculoskeletal pains, and GI upsets. This could be, very few of this is more than grade 3 or 4, but you could have at least 5% of patients complaining of musculoskeletal pains, and a small number of patients having significant other toxicities. So these toxicities need to be borne in mind when you are thinking and talking about imatinib. When you talk about dasatinib, you have mainly fluid retentions, diarrhea, fatigue, dyspnea, musculoskeletal pains, nausea, and rash. And of course, there is a lot more bone marrow suppression, which you can see at the bottom. Pleural effusions, again, in the block at the bottom, you can see can happen in almost a quarter of the patients, and this can be grade 3, 4 in about 5% of patients. So with this little bit of preamble, with Arlene's permission, I'd like to launch into my first case. Okay. So this is the first case of 44-year-old male farmer presenting with 4-month history of malaise, weakness, anorexia, and a large lump in the left side of the abdomen. On examination, he has a 20-centimeter spleen. His total leukocyte count is very high, 300,000 plus, and there's some shift, left shift in the peripheral blood with a few blasts, basophils, and eosinophils. Marrow is typical for myeloproliferative syndrome, hypercellular accelerated granulopoiesis, shift to the left. The karyotyping shows Philadelphia chromosome, and the RQ-PCR shows the BCR-able transcript, and the international scale ratio is 68.92. So we have a final diagnosis, ladies and gentlemen, of a patient with myeloproliferative neoplasm, CML in chronic phase, high SOCAL, high UTOS, high Hasford, and intermediate ELTS score. So we did counsel this patient regarding a second generation TKI, but because of economic reasons, he chose imatinib, 400 milligrams, along with hydroxyurea, 1 gram twice a day, and allopurinol was started for him. He was asked to come back after 2 weeks. In fact, he came back within 7 days of starting this treatment with a 2-day history of vomiting and decreased urine output. He was hospitalized and investigated. At that time, his leukocyte count was 180,000, and his biochemistry showed acute kidney injury with electrolyte imbalance. And you can see his biochemical parameters in the next line. His urea was 180, creatinine was 2.6, some hyponatremia, significant hyperkalemia, significant hyperuricemia, hypocalcemia, and hyperphosphatemia. So this patient was diagnosed as acute tumor like lysis syndrome with oliguric acute kidney injury. Imatinib was stopped. IV fluid with strict input-output monitoring was started. He was given rasburicase. Dialysis was kept on standby. In fact, he required 2 doses of IV raspuricase before his uric acid returned to normal. And then gradually over the next 7 to 10 days, his urine output increased, his laboratory parameters settled. On day 10, when his counts was 150,000, he was restarted on imatinib after his renal functions and electrolytes were close to normal, and he was discharged 2 weeks after hospitalization in good shape with significant improvement in general condition. So this is the laboratory parameters and the course of the patient during the hospitalization, bad kidney functions on the day of admission, which over a period of time, 7 to 10 to 14 days, gradually came towards normal. And in 2 weeks' time, at the time of discharge, his kidney functions and electrolytes were within normal limits. So we all know about the pathogenesis of the tumor lysis syndrome. There are methods to assess the risk of the tumor lysis syndrome happening. And there are well laid down guidelines for the management of tumor lysis syndrome. And now I hand over to Professor Marismo to discuss this case and his inputs on this case. Over to you, Dr. Marismo.
So thank you, Professor Malhotra. Even for these interesting cases, I believe that is an important message for all the clinicians online, no? Because we have about the classic definition, that is the Cairo Bishop definition of TLS, a clinical here TLS, because the patients developed increased creatinine level. And I believe that in this case probably is related to the vomiting that the patient experienced during the first week of treatment. This patient had more than 300,000 white blood cells. So the recent classification included all the cases of CML as a very low risk of TLS, but I believe that is not the case. That probably we have to revise this concept, of that this disease is not at the risk of TLS. So at increased risk has been considered only, for example, the AML with more than 100,000 white blood cells. So probably these patients should be managed as an inpatient and not as an outpatient, because we have to perform hydration from the baseline and to check the renal parameters. So during the treatment is a patient that we consider with a high tumor cell proliferation, very chemosensitive, and with a very large tumor burden. So probably even the association at baseline with imatinib and hydroxyurea made the difference here in this case if the patient started with normal renal parameters. And I don't know if you think the same, and Tulika and Gian Antonio have comments on this.
I was saying I'm sharing your perception, Massimo, about this case that is frequent in CML, but this is a very particular case with a synergy between a combination of Idria and imatinib on one side and the clinical problems of vomiting and during the first days on imatinib. Simply when a patient has a so expanded disease, probably not being so aggressive initially, it may be a suggestion. So starting with Idria only, and once leukocytes will fall down into 100,000 or so. So then starting imatinib, because obviously the combination, there is a very well-known synergistic effect, at least in vitro, very old data, but between imatinib and Idria. And so this was a perfect storm, unfrequent, but to be kept in mind for eventual patients like this. That's an important information for anyone.
Tulika, would you like to comment?
I agree with Dr. Rosti. And there have actually, when imatinib first came out, there used to be a lot of reports of tumor lysis with that. And so what we tend to do is when we have patients with high counts, or at the beginning, we actually start them on hydroxyurea because it takes us a few days to, one, get the BCR-able report, and second, by that time, the white blood count reduces, and we try not to give hydroxyurea along with imatinib. So once the counts are a little bit less, then we stop the hydroxyurea and we give imatinib. So, yeah.
Yeah. So it's also our behavior here. We perform cytoreduction during the first days before the initial diagnosis, even because we have the time to make the final diagnosis of molecular and cytogenetic analysis. So during these days, we reduce the burden on all the white blood cells, and then we start with the specific therapy with TKI, so imatinib or other. And if a very, very important mass of disease, we take these patients 1 or 2 days in the emergency care with hydration, and we check the renal parameters, so hyperuricemia, and we perform immediately RAS uricase and not allopurinol. That is our personal management of this setting of patients. I believe that we can consider with a very large white blood cell count like that at the increased very high risk of TLS.
Hemant, would you like to close this off and then move on to your second case?
Yes, so I think what the experts have said are very, very relevant. This is a rare but preventable acute complication during the initial treatment of newly diagnosed patients. All patients with high tumor burden, which is indicated by massive splenomegaly, high total leukocyte count at diagnosis, high and a very high LDH, should receive preventive treatment, which could be oral or IV hydration, allopurinol or other uricosuric agents, and hydroxyurea to bring down the leukocyte count before the initiating the TKI. And now our practice is to, as soon as you have a clinical suspicion of CML, a patient of a large spleen with high counts, not acute leukemia, then you start them on hydroxyurea till you get your BCR-able done, which takes 7 or 10 days. And then if the counts are less than 100,000 or around 50,000, then you start them on the TKI. And if tumor lysis syndrome does develop, the patient has to be immediately hospitalized, preferably in an ICU, hydration, dialysis, RAS uricase, and electrolyte imbalance correction needs to be done very promptly. Otherwise, this could be a life-threatening acute complication of a very treatable and curable disease. So with the permission of the organizers, I'll move on to my second case. This is a 37-year-old lady, a police woman, presented with generalized weakness of about 1 month duration, excellent performance status, no known comorbidities, non-smoker. She had mild pallor, sternal tenderness, and a 2-centimeter palpable splenomegaly. The CBC showed a leukocyte count of 74,000, platelets of 650. Marrow showed myeloid hyperplasia with left shift. The BCR-able on the international scale was 69.17, and the detection of a major transcript. Final diagnosis was myeloproliferative neoplasm, chronic myeloid leukemia, CP. Sokal score low, ELTS intermediate, and UTOS score low. So considering the age of the patient and with the TFR in mind, we started her on Dasatinib 100 milligrams once a day. And as is our policy, we call them back for the first follow-up after 2 weeks with the blood counts. The patient was, however, back in a week's time in our emergency with complaints of acute shortness of breath. On clinical examination, chest X-ray and ultrasound of the chest, she was found to have moderate pleural effusion, more on the right, bilateral pleural effusion, more on the right side than on the left side. And for the relief of her dyspnea, she required a right therapeutic pleural paracentesis, and almost a liter of fluid was drained before she became comfortable. We did all the tests in the fluid. We especially looked for tuberculosis, and the TB-PCR by the CBNAT testing was normal, and there were no abnormalities in the cytochemistry or in the cytology or the biochemistry report. The patient was diagnosed as having Dasatinib-related acute pleural effusion. The drug was stopped. She was given diuretics. Prednisolone was started, 40 milligrams per day, given for 7 days, then tapered off over the next 2 weeks. And after a discussion with her, and also like she was concerned about the cost of long-term treatment at this particular point of time, she was shifted to imatinib 400 milligrams once a day. She achieved a hematological response in 3 weeks' time. And at 3 months, her BCR-ABL showed an optimal response. She is presently on regular follow-up. She is in complete hematological remission and deep molecular remission. The last BCR-ABL was 0.015, and there are no sign symptoms of pleural effusion anymore. So again, to highlight to our delegates and viewers, it is very unusual to have early onset pleural effusion with dasatinib, but it can happen, and we have to be acutely aware and alert, and also warn the patient that if the patient has shortness of breath or dry cough, then they have to report to the hospital in time and quickly. This is the approach to the patient who develops pleural effusion on dasatinib, and the pathogenesis of this disease is not clearly understood, but it is thought to be an immune phenomena, and there are certain risk factors which have been described, especially if you give the dasatinib in a twice daily schedule, then the incidence of pleural effusion is much more. If there is a background of cardiac disease or hypertension or dyslipidemia or autoimmune disease, then the chances of the effusion are more, and it is also more frequent in older patients. So with that brief presentation, I hand over to Professor Massimo to discuss this particular rare but important toxicity, acute toxicity. Over to you, Professor Massimo.
Yeah, thank you, Professor Malhotra. So very interesting, but very rare, because I see in a lot of pleural effusions related to dasatinib, but not so faster, no, after 1 week. So I believe that we can comment also for the audience that we have to perform anytime, I believe, a screening for cardiologic and pulmonary conditions before to start with dasatinib. So probably here is a very younger patient, so no other comorbidities to start dasatinib, but it seems a possible strange situation in which probably the patients had a underlying autoimmune disease, no, because they're reacting so faster to this drug, and I see other reactivation of autoimmune disorders during dasatinib treatment. The pathogenesis, you well explained the possibility, no, of the PDGF receptor alpha inhibition and so on. So I'm totally agree that you switch it to imatinib, because this patient had received the thoracentesis, no, because he is a grade 3 or 4, I believe, toxicity if you drain it more than 1 liter of pleural effusion. So probably is not a candidate to restart even at a low dose dasatinib, because it's a too fast type of toxicity during this treatment. So probably, and in fact, answered so well also to imatinib after 3 months. So this is my personal comment. I believe this is a very strange but possible if we think that 15% of the patient can experience pleural effusions during the first year with dasatinib, and then, so as you know, become very high rate, more than 30% if it's in second line, about 25% if it's in first line in the sponsored trial.
So I agree with you with your comment on this patient. And no, I look at a couple of questions posted in the chat. It's one is from August Olatokunbo about the use of allopurinol along with Idrea, or TKI to reduce the incidence. Histamine is generally suggested to give allopurinol along with Idrea in case the patient has a high leukocyte count. So it does make sense, absolutely. And the other question is related to this case presentation from Professor Biswas. And the question is there any time point till which a patient on dasatinib may develop pleural effusion? Then I express my feeling, and then I leave a general discussion. Probably not. There is no any time point, because as Hemant presented, the pathophysiology of pleural effusion with dasatinib is involving an immune reaction or immune active determinant. So if you look at experiences with a long-term of observation, the estimated cumulative probability of the pleural effusion is increasing time by time, because, you know, during even a common flu, the phlogistic viral process can open the door to this immune dysregulation, leading to the permeability of pleura. So probably no until a very long time. So generally those pleural effusions starting for the first time after, I mean, some years or many years, the trend is they do not become chronic, and so pushing you to stop the drug. But anyway, even in the long term, you can see a pleural effusion dasatinib. It depends from the, you know, if the patient is meeting or not, the third party, I mean, the third actor, dasatinib, pleural, and phlogosis. Yeah, please, Massimo and Hemant.
So I believe there is not a median time of development.
Yeah.
So it's usually sudden, and depends, patient by patient is completely different. So usually we see this type of pleural effusions not so faster, but after 2 to 3 years, and even most of them in patients with very deep molecular response. And as you know, pleural effusions not act on the responses on progression-free survival or overall survival, even because, as Professor Hemant showed, associated with increased lymphocytosis that had an action also on the deep molecular response of the patients. So probably now we know that we can reduce the dose during the treatment, lowering the risk of pleural effusions during the treatment. But I agree with all the audience that we have to start with increased dose and then reduce after the achievement of a deep molecular response, not as a starting dose with 50 milligrams, because we have very, very few data only by MD Anderson and not by other group.
Tulika, what are your thoughts?
So again, I think all of those are absolutely valid. The only thing that I just wanted to add was that in Asia, tuberculosis is very common. And we have to keep thinking about tuberculosis in these patients. And in our setup, we've seen about 10 to 15% of these patients who keep getting recurrent pleural effusions do end up having tuberculosis. So I don't think it is connected to the dasatinib pleural effusion. It is just something that we just have to be aware of that many of these patients may also have reactivation or a new infection with TB. That's why we always send the effusion for mycobacterial detection.
But Professor Malhotra doing, I believe, no?
Yeah,
Done
so
the research for total and was
This is my-
completely negative. Yeah.
This is my take-home messages regarding this case. So acute pleural effusion is a rare but serious toxicity of TKI, especially dasatinib, which should be anticipated. And it is my, rule and principle that for every patient who's on dasatinib, I ask them every time they come for follow-up if they have any dry cough or if they have shortness of breath, and I ask for a, early X-ray or an ultrasound in case of if these symptoms are present. If the patient is symptomatic with moderate to severe effusions, then you need to stop the drug and you may need to consider paracentesis. And as Dr. Tulika has very appropriately mentioned, you have to rule out an infective cause, especially tuberculosis, and especially in the low middle income countries. And I think dasatinib does produce a peculiar kind of immunosuppression, which predisposes to infections. So that has to be, kept in mind. Once you stop the dasatinib and the effusion resolves, you can start at a lower dose with careful observation. And if there is recurrence of the effusion, then you could consider changing to another TKI. So, these are my summary and conclusions for these two cases. As all of us are aware, life expectancy of CML patients is approaching that of age-sex matched people without CML. But there is a big rider over here that this only happens if expert management is provided to the patient. And now for the newly diagnosed patients, several options are available. All patients can be expected to be exposed to TKIs for several years, and most of them for life. There are acute short-term toxicities, there are long-term toxicities, and there are some unknown toxicities which we don't know what will happen to the patient, his liver functions, his kidney functions, his brain functions, his bones after 20, 30, 40 years of exposure to the TKI. And I am a strong believer that in-depth knowledge about acute and long-term toxicities of these agents is mandatory for every clinician treating CML, and prevention, anticipation, early diagnosis, and appropriate management is essential if you want to maintain the quality of life of your patient. And TFR should be one of the goals for all patients, not only the young patients, but especially the young patients, so that you can prevent exposure to the TKI for several decades and several unknown toxicities. So over to Professor Massimo and Professor Rosti and Professor Tulika for their thoughts on managing acute and chronic toxicities in CML.
And one of you might want to address Dr. Hassan's question, when does hydroxyurea have no effect?
Until CML remains in chronic phase, most patients are sensitive to hydrea. When CML decide to move to accelerated and blascaris, of course, hydrea will lose efficacy. In terms of efficacy, if you look at, the big difference, of course, is that hydrea is unable to act properly on the residual disease, and OTKI do a very difficult work. But anyway, pharmacological resistance to hydrea in chronic phase is not a frequent, was not once upon a time a frequent event. Sometimes you had simply to increase the dose of hydrea to maintain the complete hematological response, but many patients stay well for years with low dose, 1 gram or 1.5 grams.
Yeah, and I remember 20 years back, 25 years back, when we did not have TKIs, and I was around and practicing oncology at that time. In the 90s, particularly the late 90s, that used to be the standard treatment for all patients of CML. You did get a hematological response, but there was no cytogenetic or molecular response at all. So it doesn't impact hydroxyurea, even though it does produce control of the counts, it does not impact on the natural history of the disease. And that has only started to happen with the advent of the tyrosine kinase inhibitors. I think
Yes,
Tulika will also remember that era when we had, when we used to use only hydroxyurea, and for the affording patients, we would add interferon to them. And maybe in 5 or 10% of patients, we did get some cytogenetic responses.
But we also
you did something wrong. During 90s, you was still at elementary school, probably, and then during 90s, I mean. Sorry, Tulika.
Yeah, no, but at the same time, these patients who were on hydroxyurea or busulfan, about 2 to 3% of them would progress every year to blast crisis, and that the cohort of patients we would have would get smaller over time. So I think the TKIs were very, very important, and there was a slide that Dr. Hemant was going to show about Dr. Goldman and I think all the pioneers who worked to get the TKIs for us have really changed the scenario of what CML used to be when I started my career to what it is now. So it's been a very long and amazing journey.
So I think this is extremely important. This is what is needed, an integrated approach, integrating between the treating hematologists, oncologists, with the physician, with the laboratory person. And once you do this, then you can get to a point where your CML patient will have a normal or near normal life expectancy.
That is perfect timing. An hour and a half that just disappears, doesn't it? Thank you so much, Professor Hemant Malhotra, Professor Massimo Brescia, and of course, Dr. Tulika and Dr. Gianantonio. That was a really great discussion. Thank you very much. Thank you to the audience who participated as well. And we hope to see you again. The next South Asian discussion will take place on May the 29th, same times for everyone as today. And the topics there will be the realities of long-term treatment, managing the chronic effects of TKIs, chronic complications and other challenges, as Hemant alluded to during his presentation, and the role of allo-SCT today. And we have another great lineup of experts leading those discussions. Please join us for them. I'll email links to register soon. And we hope to see you online too. If you aren't already familiar with the ICMLF Knowledge Center, I strongly suggest that you check it out. There's a wealth of knowledge there, many dedicated modules. And as you can see, with a major new module, Next Steps in CML Management, currently in development, it's going to be great. If you'd like to keep up with what's new in CML, please check out our website, sign up for the newsletter, and we will send you papers of the month, keep you up to date with upcoming meetings, webinars, links to the summaries of conferences and discussions. Looks like Nicola might have an internet problem there and the slides might have got stuck. Nevertheless, via the website, you can engage with our interactive case discussion forum, where we take difficult or interesting cases to key experts in the fields for advice or commentary. It's a really great resource. Please use it. You might like to join our social media outlets, Facebook, Instagram, X, formerly known as Twitter, LinkedIn, whichever you prefer to engage with. And well, that's it from me. Thank you again to our experts. Thank you to our audience members. Always great to see you. And I hope we'll see you again on May the 29th. Thank you very much. Good night.